Thank you for inviting me to talk about LAM, a topic dear to my heart. And thanks to Alison for sharing her story, because I think it sort of reflects where we really are in some ways in Australia with understanding. I think it's improved over the last few years, the number of people who actually understand what LAM is. I've started this title with lymphangioliomyomatosis and shortened it to LAM, as you're all aware, because we get sick of saying that word, let alone spelling it. So I'm going to spend a little bit of time talking about what the definitions are, what symptoms people might present with, how we make the diagnosis, what's the differential diagnosis if you present with cystic lung disease, what treatment options and any new advances, what vaccination recommendations are, and something that's really very important to people often is about pregnancy and LAM. So really just to talk about the difference between sporadic LAM and TSC-related LAM. So sporadic LAM is not associated with tuberous sclerosis complex, and it's thought that the gene abnormality is a somatic gene mutation. So really that means in a non-transmittable or non-heritable sort of cell. So it's not in the germline, it's in just cells in the lungs, but I'll talk a little bit more about that later. And TSC-LAM, I think we've sort of really talked about today, earlier on, about the genetics of TSC and how it's transmitted. So how common should this disease be? The thoughts are that sporadic LAM is 3.4 to 7.8 per million population, and the reason there's a range is because someone has done epidemiological studies in different parts of the world, and this is what the published sort of literature says. So we should have somewhere between 88 and 200 cases of sporadic LAM in Australia. It's probably higher than that, and I wonder if this is undiagnosed, and that probably reflects the spectrum of disease. In TSC, which is about 1 in 6,000 live births, giving it 7 to 12 per 100,000, so that's sort of 1,800 to 3,100 affected Australians. And about half of those, particularly in women, should have LAM. And I don't think we see anywhere near that number. And I don't think as yet there is a formalised screening process for particularly women with TSC and the development of LAM. And that's something that we need to look into. So mostly it's in premenopausal women. We can see it in pre-adolescents, very rarely in children, and up to the age of greater than 80 when it's diagnosed. And I think that again reflects the spectrum of disease and the severity spectrum that we see. 10% of men, possibly up to 38% in one study, but about 10% of men with TSC will have cystic lung changes. It tends to be really benign and asymptomatic, and it's only if it's screened for or incidental. It can affect all races, although some data from the United States, and again this probably reflects the diagnostic bias, is that it's more common in white females of higher socioeconomic status. I think that that's a flawed thing, and perhaps the diagnosis is not made in other ethnic groups. Presentations are enormously vague, and I think, and particularly for sporadic LAM where there's no family history and there's no clear diagnostic tests, fatigue is really common. And fatigue can have so many causes that it's such a non-specific symptom. And I think if you present to your GP with fatigue, LAM would not be on the list of differentials. Progressive breathlessness, and again, has enormous number of differential causes, cardiac causes, respiratory causes, and most people, you know, if you present with breathlessness, the most common thing is asthma without any other findings. And so an enormous number of people will be diagnosed with asthma before the penny drops. About a third of patients who get a diagnosis of LAM present with a spontaneous pneumothorax, which is a collapsed lung. And it's air between the chest wall, and you can see on this scan that, I don't know how well it presents, but there's lung with a black air in the chest case, and that's a common presentation, and at which stage the diagnosis should be made. Pleural effusion, or usually chyle, which I'll talk a little bit later about, which is basically a lymphatic fluid containing fat, is another common presentation in about 25% of people. So Less common presentations, sometimes chest pain, you get an x-ray for chest pain or a CT scan for chest pain. Cough can be a problem. Pulmonary hypertension is often a late manifestation, so not usually a presentation, although 7% of people have that at presentation. Chyloptysis, we start to get into these very complex medical terms, but that's basically coughing up this abnormal lymph fluid. It often is little plugs of sort of white or yellow material, really uncommon, but we do see that, and sometimes making it more difficult to diagnose. The abnormal lymph fluid can be present in the urine, and occasionally people present coughing up blood. So I think we heard a lot this morning about renal angiomyolipomas. I think I've even got the same picture. So we won't talk too much about those. They're fat-containing and really common in TSC LAM, and about 30% of patients with sporadic LAM will have an angiomyolipoma. So the other lymphatic manifestations, interestingly, I found they're more common in sporadic LAM than they are in TSC LAM. And this is where you get sort of abnormal accumulations of lymph fluid. I think that sort of the milky white fluid is the absolute typical. It contains a lot of fat, and that's why it looks like milk. If there's a bit of blood or a lot of blood, it can actually cloud it and cloud the diagnosis. It can occur in the chest as a pleural effusion or fluid around the lungs, in the abdomen as fluid in the abnormal fluid in the abdomen. It can occur in the urine. It can occur just causing congestion in the lungs and almost presenting as a picture of heart failure. It can occur around in the sac that contains around the heart, the pericardium. And you can even get this sort of milky discharge from the vagina, which I fortunately have never seen. I hope and apparently it can occur in the stool as well. Again, less than 1% and really rare manifestations. So, but, you know, all of those things that we need to take into, and these can be the reason that people present. This is a picture showing a lymphangioliomyoma, which is a benign tumour, which is a collection again of lymph fluid in the abdomen. Often people present with abdominal bloating, and that can be common in sporadic LAM. People get this sort of sense of bloating, particularly around the time of the period, you know, even worse than most people get with their period pains. It's present in about 1 in 5 people with sporadic LAM, and it's a growth of smooth muscle cells in the lymphatic channels in the abdomen. It responds incredibly well to sirolimus, so it could be a reason just to use sirolimus for symptomatic improvement. You can also get enlarged lymph nodes in LAM, mostly in the axial, so we say in the abdomen, in the sort of retroperitoneal is the most common, so at the back of the abdomen, but they can also occur in the chest, but very rarely ones that you can feel, so lymph nodes in your neck or in the supraclavicular area, sort of just above the collarbone. I won't spend a lot of time on this because I think that Matt covered it really well, but in TSC there's 2 abnormal genes, TSC1 and TSC2. In sporadic LAM it's felt that it's a somatic mutation. So somatic we mean, again, as I said, not in the germ cells, so not in every single cell, but in selected cells, and how that is, it's probably a spontaneous mutation at some stage. We don't know where the LAM cell comes from. There is this theory that this is a sort of metastatic or cancer-like process where the cells generate somewhere and then spread to other organs in the body. But no one's been able to find where that sort of cell originates. So it's very hard to sort of say. There was a theory for a while that originated in the uterus because it is a disease mostly of women. But that's been unable to be verified. So potentially it's just that the abnormal cells occur in different organs and at different rates. That's still not understood despite a lot of clever scientists trying to look at it. Sex hormone dependent, it is really female sex hormone dependent. And I think that that's why it seems to manifest, particularly in TSC, which is as common in men as in women, that the lung disease is predominantly a disease of women. So, when we're making the diagnosis, what are useful investigations? Lung function tests, they're very useful to determining the severity of the disease, following the progression of the disease. Initially, you may just see some gas trapping, which really is measured on lung volumes, which are the ones where you do in the body box. But normally we look for airflow obstruction, which is the spirometry or the blowing test that you do. Reduced oxygen transfer, or actually it's transfer of carbon monoxide that we measure because it's a lot more transmissible and easy to measure, and not at the doses that kill you, of course. Imaging is probably the be-all and end-all. A chest x-ray can be normal, and that's why often you'll find people present to the emergency department with breathlessness, with funny chest pain, and they have a chest x-ray and it's reported as normal. So it's a very insensitive test. It's useful for finding a pneumothorax or a pleural collection, so fluid around the lung. But the high-resolution CT test, and when I mean high-resolution, it really means that it's just a software program where they take thin cuts. It needs to be done without contrast because the contrast can make the pictures less easy to understand. And it is thin-walled multiple cysts. You're allowed to have, as you get older, you're allowed to have up to 4 cysts in your lungs and be considered normal. Any more than 4 cysts, and there's usually a pathological process going on. Most patients with LAM have multiple cysts, and the more severe your disease, the more cysts that are present. There can be other features that we can see, such as the fluid, enlarged lymph nodes. Occasionally you can get nodular changes, particularly in TSC LAM. This has been a topic that's been really thrown out there. How do we detect in somebody who doesn't have any other features? And I'll go through the diagnostic criteria in a minute of serum vascular endothelin growth factor D, and that's part of the pathological pathway that's abnormal. It's elevated in TSC and in LAM. It was established for the use in the diagnosis to try and really sort of narrow down and be more sure that the diagnosis is LAM for clinical trials in the absence of a tissue diagnosis or a big biopsy, which no one really wants to put someone through. Biopsying a lung's not like biopsying the skin. So additional features such as tuberous sclerosis, that makes you confident that you've made the diagnosis of LAM. A kidney tumour looking like an angiomyolipoma, that makes you confident that you've got the correct diagnosis. These abnormal lymph channels, lymph collections in the abdomen, that makes you confident of the diagnosis. So they came up with this. It's been verified and really only fully established in one laboratory, and that's one of the reasons that we've really struggled to bring it into Australia. A level of greater than 800 picograms per mil is diagnostic of LAM with about 100% specificity, but sensitivity is only about 60%. So if you drop down the level to 600 to 800, it's about 98% specific and about 84% sensitive, which means that you're still missing some people, and that's why a lower level does not exclude the diagnosis of LAM, but probably doesn't help you one way or the other. So we would like to do this in Australia. It again is not funded under the MBS. You'd have to pay for the test. It would be about $200 per test. But also we don't know in our individual laboratories what the numbers mean. So without a funded study in which we could work out how our laboratory cares and compares to the Cincinnati laboratory and what the cut-offs are. So at the moment we've sort of put it in the too hard basket, but it is something that perhaps going forward would be nice to be able to, we'd really need to compare to the Cincinnati lab, send blood across to see that we're getting similar levels. A lung biopsy is the definitive diagnosis as it is for a lot of things, but it has, morbidity and mortality or, injury and potential risk of dying from a chest operation. So we do this really only when the diagnosis is unclear and there's really important to get a diagnosis. There are some characteristic findings both on staining and looking under the microscope. So it's a very useful test, and we'd probably do it if you have a collapsed lung and are having a pleurodesis. When you're having a chest operation, then that's the time to do the biopsy. So this is a sort of complicated slide as well, but it really just sort of reflects what we do. often people present, you know, they've fallen off a ladder, had a car accident, have a trauma scan, which is, you know, one of the commonest things we do these days because, you know, everyone turns up to the emergency department. There's a CT scanner in every emergency department. And if you've had any form of trauma, you run through the scanner from top to bottom to make sure they don't miss any injuries. Find some cysts in the lungs, and that's often where asymptomatic people or people with really mild disease get diagnosed, and perhaps we are seeing more of this disease and often in asymptomatic people. If that's all you have, the characteristic cysts, then you can make a diagnosis of probable LAM but not definite LAM. You can only make a diagnosis of definite LAM if you've got something else. So if you've got a history that confirms the presence of tuberous sclerosis, knowing you've got tuberous sclerosis, having a family history and the list of things that sort of fit with tuberous sclerosis, then it's easy. Any cystic lung disease is likely to be LAM. So moving on, you don't have a diagnosis of TSC, so what else can you do? You do a CT scan or some imaging of the abdomen and pelvis, and you find either the renal lesions or these lymph nodes or the lymphangioliomyomas, the sort of collection of abnormal lymph fluid. Then you can say this is definite LAM. Moving on, you don't have that. Then it would be nice to have, that's when the VEGF-D levels would be really useful, but we don't sort of have, we have to skip that step in Australia to confirm the diagnosis of LAM. Then if you have chyle somewhere, you can confirm the diagnosis of LAM. But often, you know, then you come down to how sure are you? What are the differential diagnoses? Is the person the right age, hasn't been a cigarette smoker, doesn't have any other features that don't quite fit with LAM, and then you make a diagnosis of probable LAM, and we're left with probable LAM quite a lot because the extra lung manifestations are not always present. So we're often left with probable LAM. The difficulty with that is we sometimes then want to make a decision, are we going to treat the condition? And without a definite diagnosis, that's obviously slightly... you feel less confident about starting a disease-modifying drug, which does have potential side effects without a definite diagnosis. And I think that's sort of where we are sometimes. But, you know, the radiology is usually pretty convincing. So what are the differential diagnoses of cysts in the lungs? There are many. And probably the most common one is emphysema. And I think this is perhaps why we come back to that sort of, is this a skewed disease of affluent white women? I suspect not. I think it's because perhaps, you know, the penny doesn't drop. These other people have been cigarette smokers, although plenty of affluent white women smoke, certainly in their teens. Langerhans-Sill's histiocytosis is a smoking-related lung disease, and that's probably the biggest differential that I see. They're almost all cigarette smokers by definition, and often the disease will regress or stop progressing if you stop smoking. DIP, or discriminative interstitial pneumonia, is another smoking-related lung disease. LIP, there's lots of little sort of shortenings in lymphocytic interstitial pneumonia, is associated with autoimmune disease. I don't know whether you've heard of Sjogren's syndrome, which is just the name of the person who diagnosed it, but dry eyes, dry mouth, which is an autoimmune disease. And that's one of the tests we do if someone presents with cystic lung disease, is we screen them for antibodies against their own tissues. And that's LIP. And again, that's a number of people who are sent to me, is this LAM, who have LIP. Follicular bronchitis is a rarer condition and looks quite different. Amyloidosis, again, is often associated with LIP. And perhaps the other one, which is harder to diagnose, although the cysts do look different, is Birt-Hogg-Dubé syndrome, because you can get renal tumours in that as well. That's a very strong family history and runs very much in family. Male and females are the same, and they often present with pneumothorax. So once we've got a diagnosis or a probable diagnosis, what do we do? Again, the usual sort of things: don't smoke, warn of the risk of pneumothorax. It happens in about a third of people in their lifetime. at presentation, and 66%, so 2/3 in their lifetime. Use oxygen when required. There are a number of people who need bronchodilators like Ventolin and the long-acting versions of that because there's airway reversibility is quite common. I'll talk a bit more about vaccinations and a little bit more about pulmonary rehabilitation, which is a supervised exercise program which can benefit everybody. So the mTOR inhibitors are the mainstay of treatment, and I think as Matt spoke about this morning, sirolimus and everolimus are equivalent. In LAM, the only one with any evidence is sirolimus, and that was the trial. That's not to say that everolimus won't work, but certainly sirolimus is the first-line drug. We were talking today about how everolimus is the first-line treatment in TSC, particularly for renal tumours and for cerebral lesions. And again, that's just because the drug they chose for the trial and the way it was funded. It's amazing that there was a trial done in LAM with a small number of patients. It's the first and only randomised controlled multi-centre international trial in LAM. It was supported really by a drug company only for the cost of study visits and the drug. Otherwise, it was purely investigator-driven with grants from the local hospital and the LAM Association. It only included centres in Northern America and Japan. Japan because they added the numbers. Australia, we tried to get involved in that study at the time, but because of our distance and the lack of funding, we weren't included. So this was impressive. It reduced the decline in lung function quite substantially, and it was well tolerated, and a significant reduction in the rate of fall of lung function. And I think that this is a really landmark pivotal trial which will probably never be repeated in LAM. The effect was less in postmenopausal women than premenopausal women, and in fact there was not a huge change in postmenopausal women. Minor side effects. Really, I think this is a particularly well-tolerated drug overall. Some people get some mouth ulcers from time to time, bit of acne, certainly can put your cholesterol up, but we can treat that with other drugs. And really, there were very few serious adverse events, and serious adverse events mean needing to stop the drug. So we talk about this being a hormone-driven drug, so why don't we just manipulate the hormones? Well, that was really the first, when I first got involved in talking about LAM, hormone manipulation was the thing. Progesterone was studied. Again, it made no difference. In fact, perhaps there was an accelerated decline in the gas transfer, which is the DLCO. Another study showed some improved survival, but there's really no evidence for progesterone-only drugs. Other anti-oestrogen drugs, you know, trying to induce premature menopause in a young woman is not a kind thing to do, and menopause itself is pretty awful. Significant side effects, no improvement, loss of bone density, all sorts of terrible things. So at this stage, there is no recommendation at all for hormonal manipulation in LAM. So bronchodilators, these are the puffers we use for asthma, and there is certainly some improvement, and some people have evidence on their lung function testing of reversibility. So you have Ventolin and your lung function gets better afterwards. I'm sure you've all done lung function where they make you breathe in some Ventolin and see if it gets better. And if it does, then there's a role. Whether or not you need the steroid components such as Symbicort or Seretide or any of the newer ones depends on the person. There was a study looking at simvastatin, which is a cholesterol-lowering drug, particularly in combination with sirolimus. And I think that probably, you know, it does help with the hypercholesterolemia or the high cholesterol that is caused by, can be caused by sirolimus. So it does no harm by and large, so some people take that as well, but evidence is not clear. Again, many years ago, there was a bit of a fad using doxycycline, which is a widely used antibiotic. 2 trials, both were clearly negative, and this is now no longer considered to be a treatment option for LAM. Moving on, pneumothorax management. They are likely to be recurrent. So once you've had one, you're likely to get another one. And the recommendation is as soon as you've had one that you should have a pleurodesis, not wait for the second. When we see particularly tall young men, which is another group that are at risk for pneumothoraces, they should, usually it's only on the recurrence that they get a pleurodesis. Pleurodesis is now recommended to be mechanical abrasion rather than talc, because talc can cause problems in itself and also makes it very difficult if you do end up down the path of lung transplantation. So now the mechanical abrasion reduces the risk of recurrence from 70% to 30%, so it doesn't necessarily make it absolutely you won't get another pneumothorax. Again, I don't think there's any reason to have a pleurodesis if you haven't had a pneumothorax on that side. So pleurectomy can be used for resistant cases, but I think that that's a big step and a very big operation and makes lung transplant almost impossible on that side. It is estimated that the risk of flying, if you've got cystic lung disease, is about 1 to 2 episodes per 100 flights of getting a pneumothorax due to the pressure changes of flying. But I think it's probably less than that. I mean, I don't think I've had... I think I can think of one person who's had a pneumothorax on an aeroplane and didn't even notice. It was only when their lung function had fallen, we did a chest x-ray and went, oh. So I won't go through this because Matt covered that really very, very clearly, the management of angiomyolipomas, but for the people who weren't here this morning, it is recommended for surveillance every 12 to 24 months when they're less than 3 centimetres, and that's really just to detect if they're growing. We talked this morning about whether or not a CT scan was the best test or a ultrasound. Ultrasound's useful if they're quite small, perhaps not so much if they're around that when you're trying to make a treatment decision. And MRI perhaps is the best test, but currently not funded in Australia, but maybe soon for TSC-related tumours anyway. Some evidence for mTOR inhibitors if they're growing, greater than 3 centimetres or multiple, and embolisation only really if refractory, or potentially if it's the sole indication for an mTOR inhibitor. Surgical resection is uncommon, fortunately, these days, and only if they're large at risk of bleeding. And we try to keep as much of the normal kidney as you possibly can, rather than taking the whole kidney out, which has happened in the past. And we've seen people who've really run into end-stage kidney failure from having too much kidney removed. The lymphatic complications may need drainage. I think this is sort of almost a tale of two patients. Around sort of 2012 or thereabouts, or perhaps even a little bit earlier, I had a young woman who had a chylous effusion, so effusion containing this lymphatic fluid. She was in hospital for the best part of 6 months, had pleural drainage, a pleurodesis which failed, followed by a pleurectomy, then an effusion on the other side. We put her on a low-fat or no-fat diet, which, as you can imagine, is not exactly easy to take, and loss of weight, loss of conditioning. And then we made the decision that we would just give her a trial of sirolimus, and it all went away. And, 10 plus years down the track, she's stable and doing well. And I think the next case I had was again a young woman with an effusion which we drained on multiple occasions, and but we held tight. We started her on sirolimus up front. She got recurrent drains for symptoms, and but now would be 5 years down the track with no recurrence, stable on sirolimus and good lung function, and living a normal life without any of the surgical interventions being required. And I think we've not had to go to thoracic duct embolisation or I think that that's a thing of the past, and I think that sirolimus has really revolutionised this area, and it's really an indication for sirolimus up front. So, moving on to some sort of more specific things. Vaccinations. We recommend all of the standard respiratory vaccines. Live vaccines, certain things, are live vaccines that you should not have, and that particularly relates to the shingles vaccine. Shingrix is the new one, which is not currently covered by the PBS. It's about, I think, $300 a shot, and you need 2 shots. So it's about $600 you have to pay for yourself, but that's a not live vaccine, whereas the Zostavax is a live vaccine. So if you're taking sirolimus, you should not have that one. Recommended annual flu vax. If you're under the age of 65, you should have 2 vaccines 6 weeks apart. If you're over the age of 65, they give you a sort of double dose almost in itself because you're considered to have a weaker immune system over the age of 65, and then you only need 1 dose. So COVID vaccines, as per the guidelines, early on we recommended an additional dose earlier. But now it's just as per the guidelines, keeping up with your boosters. We recommend both the pneumococcal vaccines. Prevnar 13 covers sort of 13 strains of pneumococcus. Pneumovax 23 covers 23, but they're not all the same, so we recommend that you have both. And it is available, and again, for shingles vaccine, because you don't want to get shingles. So all of those vaccines are recommended. Wanted to talk a little bit about pregnancy, because I think that that's something that often comes up, particularly as this can be a disease of women in their 20s and 30s. It has been associated with accelerated disease progression, and there's certainly at least a 30% chance of spontaneous pneumothorax during the pregnancy. But, uneventful pregnancies have been reported, and I think, this is an individual decision between the patient and the clinician. We sort of say that pregnancy is not recommended, but, for some people it's a biological imperative for some young women, and therefore we've sort of moved from the place of banning it, unless, of course, the person has very severe lung disease and the risk of accelerated decline leading to respiratory failure. I think we can work with it. In patients that have, a reason to be on sirolimus, particularly such as chylothorax with lots of fluid, and stopping the sirolimus might be quite problematic. So sirolimus is not known to be teratogenic or doesn't cause birth defects, as far as we can tell, but it hasn't been tested in enough people for you to be sure. It has been associated with increased death of the baby in utero, so it's not perfect. But there are certainly quite a number of cases in kidney transplant in particular of patients having uneventful pregnancies while taking sirolimus. So it is potential that you could continue. The current recommendation is if you have lung reserve that you would stop the sirolimus before trying to get pregnant and continue it. In addition, it's excreted in breast milk, so you would not want to breastfeed your baby while taking sirolimus. So it's all a balance of risk and a balance of decision making, and it needs to be individualised and made with your doctor at the time. But we've moved away from being sort of quite dictatorial and banning things in particularly pregnancy. So pulmonary rehab does improve exercise capacity, quality of life, and your walk distance if that's important to you. Supplemental oxygen is useful if you've got symptoms. And of course, we need to keep an eye on bone density. Osteoporosis is common in LAM. So finally, the final treatment option is lung transplantation. It is a viable option for end-stage lung disease. But survival's not perfect. We were talking at lunch today about what the survival after transplant. The median survival is probably around 10 years. Now, that doesn't mean that 10 years is the limit. It means that if you transplant 100 people, 50% of them will be alive at 10 years' time. In fact, it's actually better than that in our cohort. I think these are international data. At 10 years, we'd expect somewhere around 65% of people to still be alive with the Australian healthcare system. But a lot of people will have died before that. It is a treatment of last resort, and we're hoping that we don't get too many people to transplant these days. Pleurodesis is not a contraindication, but it certainly makes the transplant surgery harder, not the long-term outcome, but the surgery and the increased risk of bleeding. Sirolimus is associated with wound breakdown, and certainly the airway joins are particularly problematic, but it can be continued right until the time of transplant, then just stopped and restarted about 3 months after transplant. Because LAM can recur in the transplanted organ. So what about new research? Are there any drugs on the horizon? I guess this is what half the people here are looking after. Hydroxychloroquine we heard a lot about over COVID. There was, again, a small study of 14 patients. And that's the trouble with a lot of these new agents, is that they're tested in really tiny populations because, again, it's a single centre sort of thing. And most of these are done out of Cincinnati. In addition to sirolimus, because it's hard not to give someone who otherwise requires sirolimus, doses up to 400 milligrams a day. The sort of standard dose in rheumatoid arthritis or systemic lupus would be 200 milligrams a day. It was well tolerated, but there was no clear benefit. Celecoxib, which we all see, an over-the-counter anti-inflammatory for, or maybe it's not over-the-counter, but an easy-to-get anti-inflammatory for osteoarthritis of any arthritis. A small, again, from the same centre, 12 patients in 24 weeks, and these were people with really good lung function who did not need sirolimus or sirolimus wasn't started. And they looked at lung function, VEGF-D levels and quality of life, and really they only found a signal in 2 out of the 12 patients who had high VEGF-D levels, that their VEGF-D levels came down. Difficult to take anything from that, and certainly this was done in 2020 and I haven't heard anything more about it. Perhaps more exciting is resveratrol, which is a drug that acts again through the mTOR pathway. But instead, unlike sirolimus, which you need to keep taking because it's sort of cytostatic in terms of, whilst you keep taking it, it keeps blocking the signal. Whereas resveratrol, they're going to have to name it something easier to say, kills the cells. So it's cytotoxic. So it's hoped that it can induce remission, so you only have to take it for a period of time and then you can stop. And I guess that's one of the things that we look for in LAM. Can we have a drug that we take and then stop? So they set up this study, which is a phase 2 early label trial, and again, only 25 LAM patients from around the country. And their primary endpoint was a reduction in VEGF-D. And I don't know how useful this is. And again, the drug was added in addition to sirolimus because it was non-ethical to take patients who have significant disease off their sirolimus. So their primary endpoint was not met in this small trial. But there was a significant, statistically significant decrease in the VEGF-D levels. Is that clinically significant? We don't know, and it probably needs a much longer trial, and so it's a watch this space. This is relatively recent, only published this year, so I think we don't know yet. It's encouraging, perhaps it's a drug of the future, but it's going to be hard to sort of prove potentially. There was some signals in quality of life, but no signal in lung function. Because again, I think perhaps they were still on sirolimus. The changes were in a small short-term study with small numbers. And when you think, I think just to sort of reflect, cardiology trials often have sort of, 20,000 people in them. So, having 25 is sort of a study that's hard to show. You've got to show a really big benefit to get a statistically significant result. So if we don't do anything, what's the rate of progression? It's extraordinarily variable. And I think that really reflects, it's suggested that TSC-related LAM has better outcomes than sporadic LAM, but potentially that's because they're picked up on screening. And I don't know that we have a systematic screening program for TSC for lung disease in adults, certainly in Australia. So perhaps that's something we need to talk about. Factors associated with more rapid decline are the younger age at diagnosis, the higher the VEGF-D levels, and if you have a bronchodilator reversibility, so your lung function gets better after Ventolin. What's not related is the level of FEV1 at the time of diagnosis and the number of pneumothoraces. In fact, the number of pneumothoraces sometimes means you get diagnosed earlier because you present. But the median transplant-free survival is greater than 20 years and is probably improving as we have easier access to sirolimus. So I think in conclusions, we've had some major advances over the last sort of 20 years in the understanding of the diagnosis and pathological pathway of LAM. Sirolimus has really revolutionised the management, and we're really seeing very few people come to transplant these days unless they have have quite severe lung disease at the time of presentation. I think we can refine the use of mTOR inhibitors. Perhaps there's more powerful drugs out there, and I think firming up on the diagnosis with biomarkers would be useful, and we continue to evolve. Thank you. Matt.
I just want to start with a question. Thank you very much for this great. You mentioned obviously the interaction with female hormones. I was wondering what advice you give your patients with LAM about oral contraceptive pills. And the second part of the question, what advice you would give women with tuberous sclerosis who don't have diagnosed LAM on using that oral contraceptive?
Look, I think the information not out. We had always sort of suggested that the progesterone only sort of Implanon. I mean, the ideal thing would be a Mirena. IUD as being really effective and easy, but obviously you need an anaesthetic if you've not had children before to implant it. So again, we recommend progesterone only, but if that becomes problematic, I actually think the oral contraceptive pill is not unreasonable, and particularly if they're taking sirolimus with monitoring. I think the hormone story is so fraught with difficulty that it's very hard, particularly low-dose oral contraceptive pill. I'm not sure it gives you any particular risks. I think we've moved away from saying don't take the pill, don't do this, because certainly, ablating someone's oestrogen production just makes them terrible, not better. I think, again, the story comes with hormone replacement therapy after menopause or perimenopause. If the menopausal symptoms are bad, then, it's a risk-benefit analysis. And again, goes with, not getting pregnant is, particularly if they've got severe lung disease, is probably more important than whether or not you take the pill. Yeah?
Does tuberous sclerosis create your lungs to enlarge, big?
Well, they can. If you get the cyst, the size of the lung can increase. Heather?
Are there any thoughts on why someone who is postmenopausal, why the LAM would continue to progress after menopause?
No, look, it's sort of, it's very difficult. And again, I think that's the sort of hormonal independent factors there as well, is because, you think that certainly if you present postmenopausal, your progression tends to be less severe. But it's not exclusive, and we do see progression after menopause. Your lungs do deteriorate from the age of 25 anyway, annoyingly, on the slippery slope downwards. It is accelerated decline, and I think that that's an indication for treatment. You shouldn't not treat someone just with sirolimus just because they're postmenopausal, but the likelihood is if it's an incidental finding and they're postmenopausal and their lung function's preserved, that it probably will remain preserved. Jeff?
When a woman's diagnosed with breast cancer, they'll often check the cancer tissue for receptors for estrogen, and then determine the treatment according to whether the receptors are present. Is there any equivalent study to say whether certain subgroups of women with LAM have more receptors than others on their LAM tissue?
Again, I think not looked at. We rarely do a biopsy these days. Unless they're having a pleurodesis, and then we'll ask for a biopsy. But I'm not sure that that's actually been looked at. Possibly there are estrogen receptors, but again, I think the downside of, when you've got breast cancer and you've got an estrogen receptor, you'll happily take something that makes you feel pretty awful. but when you're not sure that it's going to make any difference. But again, maybe it makes a difference in some people, and I think that's something that we can't answer.
The dose of sirolimus, can that change, like, is it increased over time, or do you just stay the same?
We tend to target a level, so a blood level, so everybody's different. You know, some people take 2 milligrams a day. Usually most people about between 1 and 2 milligrams a day, but some people take 1.5, some people take 3. Again, the aim is to get a level. We have chosen a level between 4 and 6, and that's what we used in transplant. And I started using sirolimus before the trial was published. So that's the target, and it worked. The trial itself targeted between 10 and a level of between 10, blood level between 10 and 15, which is a much higher dose, but the side effects were much greater. So it's a bit of a balance. If it's working, there is some evidence that if it's not working and your lung function is progressing despite sirolimus, that you should up the dose.
I might just say, Helen and I were discussing this morning because the trials that were done in kidneys have much higher level of exposure to everolimus than the equivalent sirolimus, and we were sort of saying, do we think that's a relevant thing? But the trials were sort of done with different levels. So when we're treating the kidney lesions, we often use sort of stronger levels of everolimus compared to what would be the equivalent sirolimus.
Yep.
With the sirolimus, for the lung condition, if you have heart issues as well, is it safe to use the sirolimus?
It is. It's actually a really, really well tolerated drug. You know, some minor side effects. Look, it is an immunosuppressant drug, but unlike some of the other immunosuppressant drugs we use, it doesn't seem to accelerate skin cancers in particular, which is something in Australia that we find really problematic post-lung transplant. It puts your cholesterol up. It potentially makes you more susceptible to viral illnesses, and in COVID there was a lot of anxiety. It does interact with Paxlovid, which is about the one antiviral that you can take as an outpatient for COVID. And it interacts in a really, really big, complicated way. So, but, you know, as I've said, you know, I think we had a talk with our LAM patients about this, is that if you had COVID and you were quite unwell or you wanted to take Paxlovid, you could just stop the sirolimus. It interacts with the metabolism of the sirolimus, and so, but it can last for weeks and weeks afterwards. So it's a big deal. There are other antivirals which you can give intravenously for COVID that can be given in hospital, but the molnupiravir, which is the only other oral available one in Australia, doesn't work against the current strains of COVID. So it's a bit complicated, but other than that, it's a really, really well tolerated drug. And we haven't sort of, you know, we don't know really, is there any sort of particular long-term side effects, but compared to, it doesn't damage the kidneys in the same way. Although it can cause in itself, there have been some cases of sirolimus lung where you get a funny infiltrate in the lung, but it's pretty uncommon, and I've never seen it in a LAM patient. I have seen it in heart transplant. Have you seen it in kidney transplant? Sort of everolimus lung or?
Yes, we have, but rarely.
But, yeah.
It is important to note that it can also affect the kidneys, so you do need to monitor your kidneys, particularly for protein in the urine when you're on medications, and that can sometimes mean we need to adjust doses if that does develop.
Yeah.
With your lungs, with cancer, it can transfer from one lung to the other.
Yep.
Tuberous sclerosis, can that transfer from one lung to the other?
Tuberous sclerosis tends to be in both lungs because it's in all of the cells. So it's very rarely just isolated to one lung. It's usually present in both lungs right from the start. Yeah?
I was just going to mention that when I got COVID in February.
Thanks, Jeff.
I was on sirolimus, and of course I contacted you. I started taking the Paxlovid as soon as I got the positive test. So I've got the sirolimus and took Paxlovid. I didn't notice any, interactions or side effects.
No, you won't because you stopped it. It's really only if you continue to take the sirolimus. We tried in one of our transplant patients early on, tacrolimus, which is one of the other rejection drugs. We cut the dose enormously, but the level still was way out of control and it took weeks and weeks to get it back on track.
Oh, really?
And in transplant, you don't want to stop the immunosuppressant completely because you run the risk of rejection. So it's...
So with the sirolimus, as soon as you stop taking it,
well, then basically you're not going to accumulate it. It's not going to, the levels are not going to get higher. They might get higher in the short term, but because you're not ever adding to that, it's, you know, it's starting to wear off anyway.
So we're about to publish a case series of 140 patients on tacrolimus that we successfully used Paxlovid in. So
I'm impressed you managed it because we had an absolute disaster.
I understood that I'm on the everolimus and I was taken off the tacro. I understood the everolimus would help the LAM in my third month. So is that not the case?
No, it is. Because we think that LAM can actually recur in a transplanted lung. So we've used an mTOR inhibitor. We seem sort of more comfortable with everolimus post-lung transplant than with sirolimus, and I'm not actually sure why, but things... Probably because the dosing's easier, especially when you add an antifungal agent, you get smaller doses of everolimus. I think we hope that stops the LAM progressing in this side and causing you in the remaining native lung, causing you problems, but also to prevent it recurring in the transplanted lung, which tacrolimus doesn't do. Yep.
If you've got LAM and nerve growths are about 1 to 2 mil, is it usual for them to keep growing?
It does without, if you're on sirolimus or everolimus, they can often remain stable. But if you're not, once it's there, it will usually continue to grow. Yeah?
So my question was, if you're on everolimus for kidney involvement and then you develop LAM later in life, is there a need to be on sirolimus or well?
No, one or the other.
One or the other.
Yeah, so that's what I said. In the lung disease, the trial was done with sirolimus, probably because that was what they could get at the time. In the kidneys and for the brain lesions, it was done with everolimus. But they seem to act through the same pathways. There's been plenty of case reports, so groups of patients on everolimus showing the effect it worked, but there's no what's called randomised controlled trials are considered the best, where you give people a sugar tablet, people the real thing. And it's hard to do now, because now that you've got an effective treatment, to give someone nothing it almost becomes impossible. It's ethically, wrong to not treat someone. So you've got to give them, once there's a proven treatment, it's really hard to do the trial. But we believe it's the same. But we don't actually have the head-to-head trial to prove that. Yep, and yep. Women first, of course.
Would a person who's taking everolimus also have to stop taking it before taking that COVID?
Yes.
Oh, okay.
Just that particular COVID drug. But all the COVID call centres and stuff who prescribe it are fully aware of that, and all the drugs that interact. Yep.
How likely are people with LAM to require a lung transplant?
Pretty uncommon these days. Again, it depends at the time we make the diagnosis how severe their lung disease is. There are a few historical people who've needed lung transplants because there was nothing available sort of 20 years ago, and they've sort of come to need a lung transplant now. Or people who, there are people who don't complain and don't present, and the disease evolves quite slowly. They say, I'm overweight, I haven't done any exercise, and they present with really very poor lung function, and therefore much more likely. And the disease progression can be quite different. I mean, we often see the people with the most aggressive disease and the most likely to lead to lung transplant are often the youngest when they present, sort of in their, early to mid-30s probably, with quite aggressive disease. So occasional transplant for LAM these days, but not very many.
So the spirometry thing and the size of the growth, if you've got LAM, should we be looking for other stuff as well?
We always look at baseline for other stuff, and really then if there are any symptoms or anything that's sort of suggestive of something else. But usually by the time we make the diagnosis, people either have the kidney lesions or don't, if they've got significant lung disease. So the real reasons we make the diagnosis of LAM is someone with symptoms, so breathlessness predominantly, or coming to the emergency department with a collapsed lung pneumothorax, or an incidental finding. And I think probably why we've had a bit of a jump up in the last 10 years in the number of people we know have LAM is because you present to the emergency department with some sort of injury and you get a scan. And scans are now way more common than they were even 10 years ago. You know, every emergency department will run you through the scanner. It's quick, it's efficient, and it saves them having to think too much, I think. So we see a lot of people, cysts in the lungs, often not very many. They don't have any lung symptoms, and in many occasions they're postmenopausal and nothing seems to happen. You know, they've got maybe 10 to 20 cysts, normal lung function, and completely asymptomatic from a lung point of view. And we really probably don't need to do anything with that. And they probably would never have come to medical attention unless they got a pneumothorax.
What about the lymph stuff that you were talking about?
Again, that tends to have some symptoms. And again, the kidney stuff can be the presenting. You can see people without tuberous sclerosis with an angiomyolipoma as their sort of first thing. Again, you know, they might have a bleed, or that could be the presenting symptom. And then you might, when you're scanning that, cut the bottom of the lungs, go, oh, there's cysts. The diagnosis is LAM. So lots of different things. But the lymphangiomyoseals, most people get abdominal bloating and have a scan or have some sort of imaging for their symptoms before we make that diagnosis. And again, then you can cut the bottom of the lungs and see the cysts and make the diagnosis of LAM.
There's no urine test to see whether that lymph stuff is...
Oh, only again you'd notice milk, so white urine. Incredibly rare. I've never seen it. I don't know whether you've seen Kyla urine.
I look a lot of urine.
Never seen white urine, and but it's possible. Yep.
I have a daughter who's 35 with TSC, with a significant disability, non-verbal. We haven't looked at the lungs yet. There's no symptoms. Should I do this? I guess I should I?
Yeah, well, look.
Go and have a look and just get a baseline.
Yeah, well, you should. I guess the difficulty with non-verbal and is, again, then it's the risk-benefit analysis. Because she'd need probably a general anaesthetic to do a CT scan, and that's really the difficulty. Is that So I think it comes down to if she's having imaging for something else, then it's...
We've just discovered that the AMLs on the kidneys are growing because, once again, we just thought, well, maybe we better look at the kidneys, and now we had a baseline, and then now they're growing. Yeah. So we're on everolimus, and the urologist has said maybe in 12 months' time we'll have another CT scan and just see how she's going.
Well, if it's a CT scan, just get them to run it up and do that, because then you've got a baseline for the lungs too.
We haven't had any reason to look at the lungs.
Yeah, and again, another thing that's very useful is to do spirometry and gas transfer, but again, if she's non-verbal, then she probably can't cooperate because that requires a lot of cooperation. Yeah.
I was just going to say before that, like we have the recommendations for how often we should screen for kidney issues, there are some international guidelines, and it's recommended that women above the age of 16 have a CT at the time of diagnosis for tuberous sclerosis, and then 5 yearly if they don't have the diagnosis. So that's the sort of guideline. Obviously, people are different around that, but that's the sort of recommendation. And then only to have a CT if they have symptoms in the lungs, because it's much rarer. And the other thing I was just going to add to that is, often in my patients, if they are maybe non-verbal and already on everolimus, then there's not to be gained by looking for the lung findings if we're not going to change treatment, because they're already receiving the treatment. So in that case, it may not be necessary. Yeah. And
again, it's all about risk-benefit. And if you're again on the treatment and not likely to change management, different if you're having especially if you need an anaesthetic, because that changes the risk. A CT scan, really is a pretty benign procedure that can be done really quickly in someone who can cooperate. It's one breath hold, the whole image is done, and you're on and off. It's more time getting on and off the table than it is actually doing the scan these days with the advanced scanners. So I think it's all about risk-benefit. I guess one of the things we've been talking about as a medical community today in particular is how we coordinate your care. Because I think that's something that certainly came from this morning's discussion about the fact that this is a multi-system disease, and the people who have an interest in it, and certainly in Melbourne, are not all in the same hospital. And to have a multidisciplinary team, I think that's something that we certainly see in many areas when you move from the children's hospital, where everything really is concentrated in the one place with a nice building and meerkats and, a fish tank. And you come to the Alfred and, the paint's peeling off the wall and, the roof leaks and things. It's not the same. But I think, we've been trying to say that, but most people have a predominant problem, be it neurological, be it lung, be it kidney, and perhaps that we can concentrate the multidisciplinary side of it in a team's discussion. We got one thing that COVID brought us was the ability to actually meet via the internet, either via Zoom or Teams, in a really efficient way, and we're all good at it now, and we all don't have the, oh my God, I can't be on video sort of carry on. So I think that's something that we probably should do more of. And I think perhaps the one thing that's come out that we don't do very well is the sort of the neuropsychology sort of side of this, is that no one's doing that. People do epilepsy, they good at that, and it's cohorted in a thing. Lungs are cohorted. I always like to say to people, nothing above the neck, nothing below the waist, lung doctor. But but that's not the truth, because you actually have to deal with the whole person. And I think, if the difficulty is predominantly renal, then the renal guys can look after you. We always look after, we can all do the drugs. We're all very experienced with the drugs because we mostly do transplant as well. I think the neurology side of it's different, and I think the neuropsychs or psychology side of it is really different. And I think perhaps there's, again, with mental health or all of those sorts of things, the healthcare system in Australia does that really badly. And I think that perhaps TSA, that's perhaps the sort of focus. We can sort the other sort of logistic stuff out within the healthcare system that we have, but maybe it's that could be the focus of TSA, is to provide those sorts of things, social work, psychology, neuropsychology, and making diagnoses, and really sort of assisting with getting into life. And NDIS funding should be part of that.
Are there many cases of men with LAMs?
There are 2 case reports of a man without tuberous sclerosis diagnosis. One is felt to have a sort of mosaic TSC thing, and the other person hasn't been typed, both of whom had lung biopsies to prove the diagnosis. And you do need a lung biopsy in a man to make a diagnosis, but there's 2 in the world. It's really uncommon, and it's not felt to be, and that's why we think it's a hormonal predominance. I have a couple of patients who I haven't biopsied because they're completely asymptomatic, with CT scans that are consistent with LAM, but they're male, they've not got very many cysts, they're completely asymptomatic with normal lung function, and they've, trauma. So they had their scans because, and they're saying, what's this cystic lung disease? And you can't find another diagnosis, there's nothing else, and it fits best with LAM, but without a biopsy, which I wouldn't put them through unless they had a symptom, then and I guess that's the problem. We don't know. We think that this, and certainly the symptomatic group seem to be almost all women. But there are 2 case reports in the literature.
Well, can I ask so I got diagnosed after having surgery for pheochromocytoma, and in 2004, just before that. And I had CT scan, I had everything, and nothing was picked up until afterwards. When I was after having fluid in the lung, milk-glass, etc. So it was really interesting how that wasn't picked up or wasn't exacerbated by the surgery. I was always being really, I think I've asked the question before, but it's that interesting thing of like, oh, well, I had the CT scans.
I think they probably called it emphysema.
Oh, right, okay.
I think the cysts must have been there before that. I don't think they suddenly came from the... And if you got those images up, I suspect the diagnosis was LAM. But I think that the awareness, even amongst radiologists 20 years ago, was pretty poor. And the number of scans, and I think this is again if someone's a smoker, they have a scan that's got cysts in it, they just call it emphysema. Although it does look quite substantially different if you know what you're talking about. So I think that probably someone had said mild emphysema or, must have smoked, something like that on your, at some stage. And no one told you about it.
Yeah.
Probably because they didn't want to worry you or something, so...
Oh, I get that.
Yeah.
So I did X-rays again, they go, we think
Again, as I said, a chest X-ray, it can really look very normal and would be often passed as normal. So you could easily miss on a chest X-ray. It would have to be a CT scan. Jeff?
Have they done these studies to see whether the LAM cells are present in the sputum of women with LAM? Do they cough those cells up into the airways?
They certainly can cough up chyle, but I don't think that there's ever been any sort of specific LAM cells detected in the sputum.
You imagine there might be.
Yeah, there may well be, but again, I'm not sure what that would mean.
Again, partly diagnostic, but also if you were looking to see very receptors on this.
Yeah, no, you could.
Certainly, I think there's a lot of new science now about detecting cell-free DNA within urine, for example, and I think that there may be new technologies where we get much more specific, where we can look at particular DNA or RNA in the urine or sputum that may in the future help diagnose things like that. There's certainly things like transplant very rapidly evolving.
Yeah, well, you could look for sort of, the somatic mutation in the sputum or something like that, or in a bronchoalveolar lavage might be more sensitive.
So with the donating the lungs, and I know years ago things have probably changed, that people that had emphysema and things like that, or some sort of smoking condition from lungs, that they were not really accepted to have a lung transplant. So is it things like that have changed now, that people that have got issues with lungs that could come back later or allowed to have donated lungs?
Yeah. You need to be abstinent from cigarette smoking for a minimum of 6 months before being accepted for a lung transplant. And we are pretty rigid about that. We do urine screening for the metabolites of nicotine because there is a recidivism rate. People do go back to smoking after lung transplant, which is incredibly insulting to the donor family. So we're pretty tough on that. We like people to have well and truly given up smoking, but once you've reformed your bad habits, you don't get punished for the rest of your life. Otherwise, we wouldn't treat anybody who, drove too fast, crashed their car, etc. So yes, you are certainly entitled to a lung transplant, provided you are not a current cigarette smoker. So you just need to have stopped the harm and be clearly sort of not likely to, as best we can say. I mean, we're never going to be 100% at this, eligible for a transplant.
How often would you see people in the late, 60s, early 70s or even late 70s? Where is the cut-off point for a transplant?
The cut-off point, the oldest we have transplanted is about 74, but over the age of 65 and particularly over the age of 70, you have to have nothing else wrong with you. You have to have normal kidneys, normal muscle mass, normal, and have really, it's very rarely for emphysema. It's mostly for a what's called interstitial lung disease, which is a lung fibrosis or scarring process, which tends to come on quite quickly. So you don't have years of ill health. Because often that puts other things. You've got to have normal heart. It's a small group of the people we could potentially transplant over the age of 70. There's only a few who are eligible because they have to be otherwise sort of perfect, because it's mostly about utility. Your life expectancy at the age of 75 is 10 to 15 years, whereas your life expectancy otherwise without the lung disease at the age of 20 is 60 plus years. So it's about utility. So you have to really pretty well stack up. But we would transplant, again, with reducing numbers of people who in that age group would be eligible. up to the age. Currently, we've sort of said 75. I mean, it's evolved over the years. There's been age creep as the population gets older. Perhaps as the doctors get older, we sort of go, oh, yeah, that's not that old anymore. Sorry, Jackie.
The BGF or whatever the blood test is opposed to Cincinnati, like from the Alfred, can they send them over there? And in that time limit, is it still accurate?
Again, we don't know, and I think it would have to be spun and frozen, and we'd have to sort of logistically sort of work out a plan to do that. Probably if we were going to do it, we'd need to set it up as a research project, get some funding, talk to our lab. They'd be very happy to take it and run it. And then we'd package it all up, frozen. You've got to courier it so it doesn't, change. It's got a blood product sending them overseas. There's a whole lot of, forms and issues. It's not a straightforward issue. It would take a lot of logistic planning to be able to do that. Potentially, it's something if we could sort of get the planning and we had enough people who'd be happy to donate their blood, it would be a pretty reasonable thing to do. I think we'd probably get enough numbers if we can get the money, and Frank McCormack, who's the guy who runs the lab in Cincinnati, would be very happy to facilitate that.
We actually did that a few years ago. We took, rather than donating blood, and it was sent to, we had a lab here. Yeah, they spun it down. We sent it to Sydney to David Sullivan.
Yeah.
Who then sent it to Cincinnati.
All right. Do you know what happened to all those results?
This was 15 years ago.
Yeah. More probably.
So Jess still had to commit.
Yeah. Look, I mean, again, maybe we should just look at doing that again. I mean, it's certainly but I think we also need to get a lab in Australia to run the test, so then we can sort of compare the results to Cincinnati, and then we know where are we on the spectrum, because otherwise it's nice to know that we can send the blood, but we already know what their levels mean and stuff, and is that going to add anything to it? What we really want to know is, have we got a lab in Australia that can consistently do this? And therefore we've got a reference lab in Australia, which would be really nice. If you've got a reference lab in Australia, then that's great. We've got the thing. So maybe that's what we should look at. Yeah.
What's someone else about the pseudomonas? Like, do you start that after a new diagnosis of LAM, or?
No, we start it for two reasons. We start it for people who have severely impaired, well, not severely, but have at least moderate impairment of their lung function and a lot of cysts. So less than 80% of predicted lung function, we would consider starting sirolimus, or lung function that's deteriorating with time.
So you take it off the spirometry test?
Yeah, so the spirometry test, we would look at that and we would say, okay, you've got abnormal lung function, particularly if you're premenopausal. There is a risk of, if you're postmenopausal again, and we think that your lung function, so say 78%, because of course, there's always a cut-off. You're 75 when I meet you, then I'd probably say, well, why don't we just see what happens?
Well, I think
we've gone over time.
We have gone over time, but that was fabulous. Please join me. Helen, please. Thank you very much.